Hi, my name is Dr. David M. Dickman. I'm a comprehensive ophthalmologist specializing in cataract surgery, diabetic eye care, glaucoma, and refractive surgery at Universal Eye Center in Rollsville, North Carolina. In my practice, I typically give newly diagnosed glaucoma patients a choice between pressure-lowering drops and laser as initial therapy. Studies have shown that medical therapy and laser perform equally well in lowering intraocular pressure. In my experience, patients vary in their preference for a procedure or daily medication based in part on perceived risk versus hassle and expense. As someone who has trouble remembering to take daily vitamins, I can personally appreciate the benefits of delaying or reducing the need for drops. The cost of medical therapy is also a major factor for many of my patients and can affect their compliance. I always ask patients about their prescription plan copays, knowing whether a lower-income patient has to pay $3 to $5 per prescription filled or $30 to $60 per prescription absolutely weighs into my treatment decisions. Glaucoma patients who are already on more than one medication without good intraocular pressure control are also good candidates for laser therapy. That was the situation with the patient I describe here. The patient, a 78-year-old Caucasian woman, was referred by a retina colleague for management of glaucoma OU and cataract OD. She has wet age-related macular degeneration in the left eye and dry macular degeneration in the right. The left eye had already undergone cataract surgery elsewhere, as well as macular pucker surgery and several intravitreal Eylea injections. At the time of my first examination of this patient in February 2012, she was already on dorzolamide 3 times daily to the left eye, brand name Timolol in both eyes every morning, and latanoprost in both eyes at bedtime. She was also on an ocular nonsteroidal anti-inflammatory, Acular, for her macular issues. Visual acuity was 20/40 minus on the right and 2400 eccentrically on the left due to the macular degeneration-related vision loss. Gonioscopy showed that both angles were open with a moderate amount of pigment. Space classification was C30B2 plus OD and D40F2 plus OS. Pachymetry was 583 microns on the right and 589 microns on the left. I felt that her pressures of 22 millimeters of mercury on the right and 21 on the left were too high for someone on 3 medications and suspected problems with compliance. I suggested a switch to dorzolamide timolol combination drop to both eyes twice daily in place of the 2 drugs separately to reduce the number of bottles of medication and the frequency. She was scheduled to return in 1 week for additional testing. At the second visit, visual field testing showed superior nerve fiber bundle type defect of each eye. Confocal laser tomography with HRT3 was of borderline reliability, but showed low rim volume and area and thinning in several areas of the neuroretinal rim on the right eye. Cup shape measure was borderline on the right and high on the left. At this visit, intraocular pressure was down significantly to 12 millimeters in both eyes. However, the patient had not yet switched to the combination drug. She had become confused and used all her medications on a TID basis. Despite the lower measurement that day, I was not satisfied that pressure control was steady enough to prevent further visual field damage. I felt that we needed to simplify this patient's daily regimen. We decided to proceed with laser in the hopes of stabilizing her pressures consistently at the 14 to 16 millimeters of mercury level or below, and then perhaps to reduce the number of drops she was taking. MicroPulse laser therapy with the Iridex IQ 532 laser was performed in the left eye on March 13, 2012. Prior to laser therapy that day, her intraocular pressure was 16 on each side. She was pre-treated with bromonidine to prevent a pressure spike after the laser treatment. Using the laser's continuous wave setting, I placed 4 spots as test burns to titrate the laser power based on the observed tissue response. I used a 50 micron spot and 100 millisecond continuous wave exposure starting at 500 milliwatt and increasing until a slight blanch and bubble were noted at 700 milliwatt. Subthreshold MicroPulse treatment was then applied, placing 120 narrowly spaced 300 micron spots on a 15% duty cycle to cover 360 degrees of the trabecular meshwork. The patient tolerated the procedure well and noted no discomfort. No medications were administered after treatment. The patient was instructed to continue her glaucoma medications, but to stop the Acular for 4 days. The right eye was treated in the same fashion 1 month later. 2 weeks after the first eye laser treatment, the patient was using drops appropriately and intraocular pressure was 13 on both sides, although it subsequently rose to 18 in the untreated right eye. Visual acuity was unchanged. This patient was seen quite a few times between March and June because in addition to the 2 MLT procedures, she also had cataract surgery in the right eye during that time. Following the MLT procedures, her pressures successfully dropped to 12 in each eye and are currently maintained at 11 to 12 millimeters of mercury. At the patient's last visit on September 7, 2012, I asked her to eliminate the dorzolamide and use only timolol in the morning and latanoprost at bedtime. As mentioned in the introduction to this case, I like to be able to give patients a choice of laser or medical therapy. In settings where I've only had access to an argon laser, I was much less likely to offer laser initially because of the potential complications and lack of repeatability. Both selective laser trabeculoplasty and MicroPulse laser therapy appear to offer advantages in terms of complications and repeatability, and in my opinion are far superior to argon due to the lack of thermal tissue damage. When it came time to purchase a laser for my new solo practice, I considered both of these newer technologies. MicroPulse therapy with the IQ532 nanometer laser offered several advantages. Clinically, its thermal effects may be even better confined to the target tissues than SLT because of the MicroPulse technology, but the business considerations really made the choice a no-brainer. The IQ532 laser is more affordable than even a used SLT laser. It is portable and very durable. I've been able to use it for other procedures, including focal laser and panretinal photocoagulation, while the SLT laser can only be used for laser trabeculoplasty. MicroPulse laser trabeculoplasty has been the right choice for my practice and one that allows me to offer options beyond medical therapy to many of my glaucoma patients.